if I got screwed like this as a physician, what the hell is happening to people who don't even know there's a such thing as genetic testing, who don't even know that their father and grandfather's prostate cancer is important to the fact that they're at risk for breast cancer? What is happening to those people? It was a slap in the face to now be told, yep, all along you had this mutation and it didn't have to go this far. It didn't have to get this bad. I didn't have to have breast cancer, breast cancer, breast cancer, or breast ovarian cancer as the family history. That even my dad and my grandfather's prostate cancer history was relevant, and my grandmother's colon cancer history was relevant. And that's what I presented when I was asking for that genetic testing, but was still wrongfully denied. Or if I had known 6 months before that, or however long it was before that, when I asked for the genetic testing, maybe I wouldn't have had cancer at all.
This is Genetics for Healthcare, a podcast for patients.
Hey, welcome to another episode of Genetics for Healthcare, a podcast for patients and their caregivers dedicated to helping you become a more effective advocate for a precision medicine approach to your healthcare, which includes disease screening and treatment, survivorship, and prevention. You can catch us on geneticsforhealthcare.com. From there, you can go to all of our social media platforms to get episodes, updates on new incredible content like this one. Today, I am privileged to have Dr. Alexia Gaffney Adams, and she's got an incredible story. Dr. Alexia, thank you so much for joining us and sharing your story.
Thanks so much for having me on, Rome. Excited to share, particularly on your platform, because I love what it is that you're up to.
Thank you. Thank you. So, um, good friend Kathy Baker sent me your story, which I think is incredible. You are an actual MD, a medical
Mhm.
doctor. You take care of patients. Tell us about your path to medicine. What attracted you to a career in medicine, and what's your particular specialty?
Sure. So I'm an infectious disease doctor, but I actually went to medical school to become a pediatrician. I was of the mindset that if we're going to create healthy adults, we have to start with healthy children. But as I went through med school, I began to love the care of adults. And I realized like you can make a healthy change in your lifestyle. You can shift your health at any point. Doesn't solely rest in having had good pediatric care or having a healthy start to life. But as I continued through the med school path and was able to pick what I wanted to do, I would often land in infectious disease spaces, which is what ultimately became my specialty, particularly in the space of HIV care. And I was in spaces of HIV care for children, teens, and adolescents, as well as for adults and specifically women. And so, again, still didn't leave med school thinking I was going to be an infectious disease doctor, but instead of doing a pediatrics residency, I did a combined residency in both internal medicine and general pediatrics. And along the way, I hate to say it, but I got a little bored with just the basic primary care stuff in the clinic because I knew I was going to be an outpatient doctor. And so I landed on an infectious disease rotation, was very good at it, got along amazingly well with the staff and the trainees. And I loved the time that I got to spend with patients. And when I really looked back and reflected on what my life had been, I'd actually lost two very important women in my life to HIV/AIDS. The first was my godmother when I was a very young child, early in the HIV/AIDS epidemic, probably before they named it. And then I lost my god sister to HIV kidney disease. And that was before a person living with HIV could get a kidney transplant. So now my life, my practice is that of an infectious disease consultant and an internist. And I take care of people with acute and chronic infections, as well as take care of primary care patients in an outpatient setting.
So the reason why I wanted to connect with you is because, first of all, you are a doctor in a healthcare system taking care of patients, but your genetics for healthcare journey begins very young when cancer impacted your life. Tell us about kind of what was the process or the events that led up to you discovering that there was something wrong and then being diagnosed.
Yeah. So unfortunately, my breast health journey and my genetic journey was 15 years in the making. Found my first breast lump when I was 20 years old, just graduating undergrad on my way to med school. And so I had to navigate that, trying to figure out what this lump was in my left breast as an uninsured 20-year-old Black woman, right? And I just kept getting told, well, you're too young to have cancer. We don't know what it is. Go away. And eventually I would find out that that was a fibroadenoma. It was a benign tumor. It was removed well over a year later because it was growing rapidly and causing me pain. And for the next 15 years, I didn't really have any breast health issues. I did monthly self breast exams, like I would encourage anybody to do. And I was fine until one Sunday night in the shower and I found another lump in my left breast. And it felt, kind of like a marble. It wasn't hard like a marble, but about the size of a marble. I brought it to the attention of my primary care doctor immediately. And the first words out of her mouth was, "You're a young Black woman. If this is breast cancer, you're more likely to die from it. We have to be all over it." So I went and got an ultrasound and was initially told that it looked like a fibroadenoma, but days later was sat down at the desk of my primary care doctor behind closed doors and told, "This looks like something serious." And at that time of my life, I was navigating a separation. I was, raising a young child. I was a brand new homeowner and my practice was growing and I didn't have time for breast health issues. So I was like bargaining. I was like, well, it says we can look back at it in 3 to 6 months. Let's just do 3 months. And she was like, absolutely not. You're a young Black woman. If this is breast cancer, you're more likely to die from it. It's more likely to be aggressive. We got to be on top of it. So that ultrasound led to a biopsy, which landed me with not my cancer diagnosis yet, but with a lumpectomy, because the biopsy showed LCIS or lobular carcinoma in situ. And that is a marker for increased risk for breast cancer. When the entire tumor was removed, it didn't have one, but it had three different types of pathology in that specimen.
Hmm.
So it had the LCIS, which we knew from the biopsy, and it also had ALH or atypical lobular hyperplasia, and that was like wrapped up in a fibroadenoma. So the glandular tissue of my breast, not the ducts, but the milk making cells were just growing all out of control, but not yet cancer. And then there was other cells, the fibroadenoma, which is just multiple types of breast tissue just present in abnormal proportions. So it was a huge signal that, hey, something is going on in this woman's breast, and you all, my healthcare team, have to keep an eye on it. So, because of that, the breast surgeon who operated on me put me in the care of a medical oncologist and said, we need to enroll you in a high risk program. We have to keep a close eye on you. And for the next 2+ years, I would get breast cancer screening every 3 months. So every 3 months, I went on the wild goose ride of breast ultrasound coupled with a mammogram because I was young and I had dense breast tissue, which is an increased risk. And then that would be alternating with breast MRIs. And periodically, I would get a biopsy. I had another subsequent lumpectomy. And after a while, my primary care doctor was like, listen, you have two ticking time bombs on your chest. Like, just get them cut off, get a new pair, like, stop playing around with this. And so I presented this to both my breast surgeon and my medical oncologist because by this time, I'm now taking tamoxifen, which is a chemotherapeutic type of drug that stops the breast tissue from responding to estrogen in the hopes of decreasing cancer risk in someone who is high risk. So I presented that question to my doctors like, yeah, why we keep looking for breast cancer every 3 months? Why can't I just cut my breasts off? And my breast surgeon said, no, that's too radical. We don't want to do that. We're keeping a close eye on you. We're watching things. Don't worry. So I started bargaining, right? I said, well, if I have a genetic mutation, then you have to cut my breast off. So what about genetic testing? And he was like, nope, you don't qualify for that.
Okay,
So
wait. So, so okay, there's something really instructive for those who are watching, right? So first of all, you're a young Black woman who's diagnosed with breast cancer, which I kind of qualify you for genetic testing, but there are guidelines and specific things that they have to do. But why do you think that surgeon was okay? This is your wish. Was it a risk for him as a surgeon, meaning like risk to you and morbidity, mortality, or a risk for liability for or a risk financially for not getting paid for that because there's no compelling medical reason to do a double mastectomy, which he said, well, that's radical. But this is your care. This is kind of what you wanted, what you requested. Tell us about that.
so I can't say what his reasoning was. And I will tell you that over the year that I was in treatment and over the subsequent years when I was just by becoming a breast health advocate and sharing my story and interacting with and advocating alongside of other breast surgeons, particularly women breast surgeons, that feeling went from he did the best that he could with the information he had at the time, and he's doing a really great job, and I'm glad that when I got the MRI that ultimately diagnosed my breast cancer, I'm glad that he had whatever gut feeling he had that made him pop back in the room and say, hey, let's get an MRI even though you just had this normal mammogram and unremarkable breast ultrasound. But in retrospect, and now years later, after discussing my risk, there was really no good reason for him to not honor my request. And I now know also that as the breast surgeon, he's not qualified to say if I can get genetic testing or not. So once it was determined that I was high risk enough to be taking tamoxifen and being screened every 3 months for breast cancer, whether we knew I had a genetic mutation at that time or not, I had enough of a risk. I had such an increased risk that doing the surgery would have been medically appropriate, and medically appropriate for so many reasons beyond just preventing breast cancer, right? It would have been medically appropriate because the aggressive treatment that I would have needed once I developed breast cancer ended up being so much more costly than a prophylactic surgery and ended up giving me so many medical complications that will last me a lifetime, that give me increased morbidity and mortality and have the ability to even reduce my life expectancy. All of those things could have been avoided, and you can't put a number on that, right? So I don't know what he was thinking. Some days I make up a story that he wanted to be a hero and save the day because he knew I would ultimately get breast cancer, but that is just my emotions speaking. Um, and I go through a lot of emotions even 7 years later about what happened to me. But part of managing those emotions is sharing my story as a different way to channel my pain and anger around that, in the hopes that somebody else does not get denied a preventative surgery and does not get denied and does not have a delay in genetic testing that they ultimately need.
And you were also being seen by your oncologist. Did
Mhm.
you have this conversation around genetic testing with the oncologist?
Oh, absolutely. Absolutely. Because I felt that, all right, well, I see these two doctors 2 weeks apart. They're on the same team, they're in the same building. They should be doing tumor boards together. I know that they have multiple other mutual patients besides me. So this is going to come up. So let me just ask her, you know. Dr. So and so, I want to get a prophylactic mastectomy. What do you think? And she said, no, that's too radical. And so I was like, what the hell? Is everybody around here reading the same script? Like, how is it too radical? So then I said, okay, well, what about genetic testing? If I have a mutation, you have to let me get my breast cut off. And she was like, no, you don't qualify for genetic testing, which I now know today was untrue. It's just that I didn't know it at that time. And at the time I was receiving care from these providers, I have people within our health system telling me, oh, you have a dream team. These are the best. Someone from the E-suite of our hospital had gone out of their way when I had the first abnormal biopsy to, let me cut the line and see the breast surgeon, right? Normally his wait is like 6 months for a consult. I saw him in less than 6 days.
Yeah.
I think we called on like Tuesday or Wednesday and I saw him Friday. So here I am believing I got the best of the best. And, they've gone out of their way and, I want to say overextended themselves, but it's not an overextension, right? We signed up, we pay money and we train our whole lives to take care of people. So anything we do above and beyond is not an overextension. It's just what's necessary. But, having all of this stuff in my mind at the time, I just was like, well, this is their expertise and they know better than I do. Who am I to question? These are the top, these are the best. Like everybody says, this is who I should be seeing. And really, I should have gotten a second opinion, but I think I was sort of operating like, well, I do the absolute best that I can do for my patients. So I think they must be doing the absolute best that they can do for me. And if everybody says they're top of the game, then I have to agree with the experts. Like I wouldn't let them question me about the care of an HIV patient. But I should have just gone to get a second opinion.
The reason why this is so incredibly powerful, is that you are a physician. These are your colleagues.
My colleagues, that was such a big part of how I showed up. And it wasn't a consciousness thing. But in retrospect, like every time I tell my story, it's like I didn't want to question my colleagues. I assumed because they were my colleagues, they were doing the absolute best for me. But at the end of the day, I still have to remember like I live in a Black woman's body. And for
Mhm.
4 years of med school, I transcribed lectures that at the end of every lecture for every disease state, it always said Black people did worse and Black people died more and Black people had worse outcomes. So I'm existing in a healthcare system where everybody has already been let off the hook if the Black person dies or if the Black person has a bad outcome because it's been ingrained in our minds that we just do worse, but we do worse because of systemic racism. We do worse because we don't receive healthcare that honors us or that meets our specific needs as people who are going to get diagnosed younger and with more aggressive cancers and 40% more likely to die, right? People aren't treating us that way. They're patting themselves on the back because they're like, well, I would treat you just like I would treat my mother. But if your mother is a older white lady, what good is giving me the same care that you're giving her? So those are the things that didn't immediately come to mind when I was going through, but they are the things that I am educating the community on when they're going to face doctors and when they get hit with that type of messaging. Like, you can't accept that. Yeah, yeah, we assume that this person would give their mother the best care, but if their mother doesn't live in a body identical to yours and she doesn't have the same outcomes and the same risk for death or treatment failures and complications, don't accept that.
And here's the reality, and this is why we do genetics for healthcare. It is literally to help give our viewers the language and the confidence to advocate for themselves, even when that means pushing back against a clinician who may have a different opinion. Seek a second opinion, inform yourself, because sometimes, even though we do believe that physicians will always want to do the best for the patient in front of them, there's no question there. We don't necessarily question that on our show. However, the reality is with genetics and genomics, these are new conversations for many clinicians. There are many that we're finding more about genetics and genomics and their implications for our health, treatment, screening all the time. And hey, they just might not be up on those things within the best efforts because they're super busy, just like we all are. They take care of patients. When something is printed in the New England Journal or the Lancet or all these medical journals that are out there, it's not like they have the opportunity to read it on the way to work. Okay. So it's important to arm yourself with this information because, from what your colleagues that I've interviewed and had on my show, they actually do appreciate informed patients that can bring them this type of information because they know even their best efforts sometimes can be supplemented by more information or a patient who's just on top of things. Okay, so you've talked to your surgeon, you talked to your medical oncologist, and you're kind of in this fight of advocacy, but at the same time respecting your colleagues. How was your cancer ultimately diagnosed, and when was genetic testing introduced?
I'm gonna backtrack just a little bit for what happened in the months prior to my breast cancer diagnosis. I had a number of biopsies over the 2 years, 2+ years that I was being screened after finding that lump. Had, my repeated ultrasounds and mammos and MRIs. And about 8 months prior to my diagnosis, 6 or 8 months prior to my diagnosis, I had a routine MRI and a breast biopsy was requested by my breast surgeon. And the day I was supposed to get that biopsy, coincidentally, I had a follow up visit with the medical oncologist who's also co managing and has me on the tamoxifen. And she said, they're going to make a pincushion of you. Let's see if you really need this biopsy. I want you to go to the radiology place you had your previous imaging at because our machines are better than theirs. And I want you to bring that disc back and we're going to go over it with the breast radiologist who's going to do the biopsy and see if you really need it because you're high risk and everybody's going to want to stick a needle in everything. And so let's just see, do you really need to do this? So, I happily skip my butt on to the local radiology place, ask them to burn me a disc. They'd give it to me on the spot, go back to the radiology suite where I'm supposed to have this MRI guided biopsy. And the three of us huddle in the office. And my boyfriend at the time is like sitting in the waiting room because he was accompanying me to this procedure that day. And they look at the imaging and we're all in the dark room and I'm just kind of like huddled over their shoulders and the breast radiologist is like, well, this was there a year ago, they didn't call it, so because they didn't call it when I read this film, I thought this was new. So I think it's just some schmutz. That was like his literal language. And because the schmutz hasn't changed in a year, I don't think we need to stick a needle in you today. And so um, he was like, just, keep up with your routine screening, but let's forego this biopsy. And I remember being so happy that I wasn't going to have to stress my family out. Like, is it breast cancer or not? Because now we've spent over a year and a half, every 3 months or every couple of months, every other screening, trying to figure out, do I have breast cancer? And I was just happy to not have to go through a procedure and to not have to put my family through that. So didn't do the procedure, but I sort of was like, well, maybe I should. And then I was like, maybe I'm being dramatic. I don't know. So anyway, I go see my breast surgeon now in February of 2018 and I saw him immediately following a mammogram and a breast ultrasound and they were unremarkable. And so and he asked me some questions, are you feeling any lumps or bumps? He did a clinical breast exam. Of course, I was doing self breast exams and I didn't feel any lumps or bumps. I had lost a lot of weight. I lost like 20 something pounds intentionally trying to risk reduce because I understood I was at a high risk. I stopped eating meat, I stopped drinking dairy, and all the things that, people would do. By this point, I think I was like several months into a vegan diet that I started after that, don't get the biopsy. So I just was like, well, let me see what I can do. So anyway, so we do the exam and he's like, all right, well, your next imaging, you'll do it in 3 months and I'm going to go write this prescription. You can get dressed. Now, I didn't even get out of the pink little hospital gown that I was in. And my surgeon burst back through the door of the exam room. And he's like, you know what? I just want to compare oranges to oranges. Your last MRI was 6 months ago. I want you to get an MRI now. Like, I don't want you to wait 3 months. Get this MRI now. In my mind, at that time, it was, some hunch, some gut feeling, maybe something he felt on exam. I don't know. But I just thought, okay, if he wants me to get an MRI now, I'll get an MRI. And 2 days later, they were like, your MRI is very abnormal. We need you to come in and get an MRI guided biopsy. And when I walked into the MRI suite, there was like 7 or 8 people in there, technicians, the people who were running the MRI machine, the breast radiologist, the breast radiology fellow who was training and was going to participate in this procedure, the nurse who was the one who was like holding my hand and like holding my legs down as I was kicking and screaming through this very painful procedure. So there's just lots of people in the room. And my imaging was up on screens across the room. And by this time, again, I mentioned I had lost weight. I had been on tamoxifen, which actually shrinks your breast tissue. So, in my barely what's left of my breast after lumpectomies and biopsies and weight loss and tamoxifen, on my MRI imaging that was across the room, it looked like someone had shoved an orange inside of my barely B cup breast. And when I saw that on the screen, that's when I knew I had breast cancer. Because where did that come from? I was just huddled over trying to even see what my oncologist and radiologist were looking at just months earlier. And now here's this big old mass in my little boob. So I knew in that moment I had breast cancer. Went through the very painful procedure of having a breast MRI. And I don't say that to scare anybody from doing it or getting the answers I need. But after having lots of lumpectomies and biopsies and needle localizations, that was by far one of the more painful awake procedures that I've had. So, because I've had 3 lumpectomies and many biopsies, I know it takes 2 days for benign pathology to come back. So, when 2 days came and went, I didn't get a call. I said, okay, I have breast cancer, and now they're doing tumor markers and special stains and all of that. And by this time, I had to let somebody in on what was going on because I didn't tell my family again because I was not going in there expecting to have breast cancer. I went in thinking there's going to be some more benign stuff, and I'm not putting my family through the mental agony of does she have breast cancer? So I didn't tell anyone. So I ultimately told my sister, hey, I had this biopsy and I think the results are going to come back bad. And she was like, no, it's the holiday. It was Easter time. People are on spring break. The team is probably just behind. They're probably short staffed for the holiday. You don't have breast cancer, don't worry about it. And so day 5 rolled around and I was sitting at my desk in between patients because, of course, I just kept working and taking care of people while I'm waiting to find out if I have breast cancer or not. And in the exam room, I mean, in my office, sitting at my desk, and the phone rings, my cell phone, and it's the number for the cancer center, the breast center, rather, which I know by heart, because I've been calling it and getting calls from them for years. So it was the breast radiology fellow who participated in my biopsy. And, she said, this is Dr. So and so. Um, I'm calling you unfortunately to let you know that as we suspected, you unfortunately have breast cancer. She said someone from the breast surgeon's team will call you within the hour. I believe that they're going to want to see you today or tomorrow. Are there any questions that I can answer for you right now? And I said, nope. Thank you so much for that information. You have a good day. And that I ended the phone call. And that was how I found out I had breast cancer. And that's why I say it was a 15 plus year journey and really truly a 2.5 year journey to finding out I had breast cancer. I know we have many stories of someone just goes and gets their mammogram, or they find a lump, they go get that lump image screened, and oh, I have breast cancer. But my story is so twisted and so long and drawn out. And there's just so many important points to my story. So I think it's so important to give like every detail of it.
Absolutely. Did you have a family history that you know of cancer or breast cancer?
So my grandfather, my paternal grandfather, he died from a very aggressive prostate cancer. And oddly enough, I was like doing end of life care with my grandmother and my uncle for him when I found my lump, and as I was about to start med school. He died just before I started med school. My dad had prostate cancer, which was diagnosed pretty early, reasonably early. And of course, I was like, You saw what that did to Poppy. Like, get that thing out of your body. You're having a total prostatectomy. We're not playing with this. We're not doing radiation and chemo. Get it out your body." And he's fine. My mom's mother, my maternal grandmother, she died from metastatic colon cancer. And on her side, she had a niece or a great niece who had breast cancer probably in her 40s or 50s, fairly young. And then someone else on that side of the family had breast cancer. Only after I was diagnosed with breast cancer and we were trying to further explore family history did I find out that my grandmother may have also had some sort of gynecologic cancer, possibly uterine cancer. My mother's not certain. She just remembers that my grandmother had a lot of pelvic issues and then had a hysterectomy, total hysterectomy, very young. So we knew everything except for the possibility of the uterine cancer, and my medical team was well aware of that. And I remember in my preparing to advocate for myself, like looking up and knowing that I didn't have to have breast cancer, breast cancer, breast cancer, or breast ovarian cancer as the family history. That even my dad and my grandfather's prostate cancer history was relevant, and my grandmother's colon cancer history was relevant. And that's what I presented when I was asking for that genetic testing, but was still wrongfully denied.
So, at what point now that you're diagnosed, who introduced genetic testing? What did they explain in terms of what it is and what information would be gathered to be able to act on?
Yeah. So literally, I was walking down the hall with my medical oncologist. I can't remember if I was coming back in to see the surgeon or if I was specifically there to see her, but I just remember we had this conversation walking down the hall when I was post op. And she said, "Well, you're young, you're only 37, and you have cancer in both your breasts. So you need genetic testing." And it wasn't until I had the cancer and that it was also found in the pathology on the left breast tissue that I insisted be removed prophylactically. It was only then that the genetic testing was offered by the medical oncologist.
When you got your test results, how did they hit you? What was found?
So I was found to have a PALB2 mutation. It's very similar clinically to a BRCA2 gene mutation. And then also, I was found to have an ATM variant, VUS variant of undetermined significance. And so when I got that information, of course, the first thing I thought was like, I could have had a prophylactic mastectomy.
Mm,
Like I could have had a V8. I could have had a prophylactic mastectomy. Like we did not have to wait for me to have cancer in both my breasts and now need chemo and radiation and to not have even the best aesthetic surgical outcome because my cancer was so advanced. It was like invading into the fat under the skin of my breast tissue, so they had to like carve it out. So I was like it it was like metastasized in my chest wall, it was in my lymph nodes, it
mm.
had broken out of the capsule of the lymph nodes. So this was a very advanced cancer. So it was a slap in the face to now be told, yep, all along you had this mutation and it didn't have to go this far. It didn't have to get this bad. Because for all I know, 6 months prior, I could have had breast cancer. But if I had known 6 months prior I had cancer, or if I had known 6 months before that, or however long it was before that when I asked for the genetic testing, maybe I wouldn't have had cancer at all, or maybe it would have been a very early cancer and I wouldn't have had to have aggressive chemo and all the complications of chemo and radiation and all the complications of radiation and a total lymph node dissection and all the complications of that. So I hang on to those what ifs every day because every day I'm living with a symptom of the breast cancer, the surgery, its treatment, and all the complications of the treatment.
So at some point, you became empowered to advocate for yourself, right? And all those touch points in the story and your journey that you've just been telling us, even though you are a licensed medical professional, you're a clinician, you take care of patients, you still would default to the opinion of your clinicians. And I just think about all the people who are not MDs that don't have letters behind their name and not even, medically inclined that will default to what their care team says because we put that trust in them. But what was kind of the point where you, in your patient experience, felt most empowered to be an advocate, not only for yourself and your care, making sure that you got what you wanted and felt that you needed, but also speaking out publicly to raise awareness?
Yeah. I Once I knew what I was dealing with, I was like, okay, I have to take control of this situation because the people in charge have failed me.
Mm,
And so once I knew I had cancer, I was like, all right, well, the ball has already been dropped. And so I started advocating even harder and not just accepting their opinions as soon as the cancer diagnosis happened. So my surgeon asked me to come in and see him the same day I found out I had breast cancer. And I was like, nope, because I'm not coming alone. I need my crew with me. I need extra eyes and ears in that room. I need people who are going to speak up with me. And I need time to rally my troops. So I'm not coming alone to this visit. Right. So my big sister came with me. I had to let my best friend in on what happened. She came. She's a pediatrician, but she's like a fierce advocate. She's always been a patient advocate. She is the patient advocate for our other friends living with sickle cell and other chronic medical conditions. Like she's going to make noise in the room for you. So I bought her. And then my primary care doctor actually joined that visit with us as well.
mm,
And I sat right next to the doctor at the computer at the desk, and they kind of sat around us in the room. And, my best friend was taking notes, and the other two were listening attentively and jumping in. So my surgeon actually offered me a single mastectomy. He went over all the options and then he said, but my recommendation is that you have a single mastectomy, for aesthetic reasons, all these different things. And I was like, nope, absolutely not. I am not going to spend the rest of my life trying to figure out if I have cancer in my left breast. I want it completely removed, take it off. He let me know at that time I was probably going to have chemo and then radiation. And then we set up an appointment with the oncologist for after the surgery. So um, it was only that the breast cancer was found on the left side that had been missed by the mammogram, the ultrasound, and the MRI. It was only found in pathology. And I don't know if the fact that I had cancer alone was going to be enough to make these people give me genetic testing, or if it was solely the fact that it was in the other breasts. And I think it was for them more of the fact that it was in the other breast as well that ultimately made them say, oh my God, we got to get genetic testing. But from that moment when I found out I was diagnosed, I started, just rallying for myself and advocating for myself and bringing people into the room with me every time who were going to speak up, ask the questions that maybe weren't on the forefront of my mind, or, ask like, well, how's this going to affect her daughter? How is this going to affect her relationship and her boyfriend? How is this going to affect, what else do we need? Who else do we need to call in? And so once I started flexing that muscle of self advocacy, it just didn't stop. And everything, chemotherapy. What chemo am I taking? Well, should I take that? It's really toxic. Oh, okay. There's an increased survival benefit of 17%. Okay, I'll take that. Um, and then in terms of using my voice, I felt like if I got screwed like this as a physician,
Mm,
what the hell is happening to people who don't even know there's a such thing as genetic testing, who don't even know that their father and grandfather's prostate cancer is important to the fact that they're at risk for breast cancer? What is happening to those people? And then from my personal lived experience, my grandfather um, never had the benefit of chemotherapy. He was made to believe he was dying years before he died. My grandmother did not take chemotherapy. I think that was a personal choice for her. I know she had surgery, but I think that we lost out on years with them because they didn't have the benefit of chemo. And I was like, I'm doing this chemo. I don't care what anybody else says or thinks, because I gotta live. I have a 6-year old that I want to
yeah.
see grow up and go to college and see what and who she's gonna be in her life. I have nieces and nephews that I love. I have so much going for myself. I want to get back to my patients. So I was going to do everything that it took, and I was going to make all the noise in the room for myself, and I was going to share that lived experience via social media, because that was a time where there wasn't for the Breast of Us, or there wasn't well, maybe there was a Touch Black Breast Cancer Alliance, but they weren't all over my page.
Right.
But there wasn't Black women's faces, and there wasn't young women's faces in the breast cancer space in 2018. And I was like, if I'm going through this and I'm getting screwed, somebody else is going through it, and somebody else is going to go through it. And I need to share this, and I need to bust up some of the misinformation that is being put out there, and that is also causing harm to young women facing cancer.
What was so gripping when I heard you tell your story is you said, I should not be a breast cancer survivor. I
Hmm.
should be a cancer previvor. And it just, it's like a punch in the chest when you think
Hmm.
about, and I guess the question here is, what lessons do you think healthcare systems or the healthcare community at large can take away from your experience regarding genetic testing for high risk individuals and prioritizing preventative measures for
Hmm.
early genetic testing for individuals like yourself who they may not know the guidelines and may not know that you qualify when you do. They may not know that genetic testing is actually affordable because there's
Hmm.
the prevailing mindset that this is thousands and
Yeah.
thousands of dollars. We don't want to
Yeah.
expose, financial toxicity to something that you may not need. What can they take away in order to properly, you know, consult these patients who can really benefit from genetic testing?
Yeah. I think, we have to look at patients as individuals, and we have to pay attention to what is happening as healthcare professionals. And sometimes you just got to say, maybe the patient is right on this one. Maybe like this patient is living in this body every day. This patient has these lived experiences based on family medical history. Maybe I need to find out, why is this so important to them? What is the fear? What is the concern? Why do you think you need this test that I don't think you need as a healthcare professional? Like, let's start questioning our own decisions and our own judgments. Like, is it because we want to just hurry up and get out of the exam room because there's 20 more people waiting?
Mhm.
Is it that you're fearful that you're going to have to fight with the insurance company over the cost of this care or this test? Because one of the other things that stood out for me is, once I got the cancer diagnosis and I needed a PET scan and a bone scan and a CT scan, every time a diagnosis had to be authorized, I would get a phone call and I would get something in the mail that said, your doctor requested this thing, and you know, authorization is pending approval, or, this test has been approved, denied, whatever. And I never got that from either provider around the genetic testing. So the you didn't qualify just came straight from their mouth, their gut, their heart, their mind, whatever. It didn't come from medical decision making, or it didn't come from an insurance refusal to authorize the testing, right? It just came from, the buck stops with me. So really, yeah, so providers need to ask themselves, like, really, does the buck stop with me? And if the patient wants this and it is reasonable and it is not harmful for the patient to have this, maybe I should give the patient the decision, do they want to pay for it out of pocket? Because no one discussed with me the cost. And I've had dinners that cost more than it would have cost me out of pocket to pay for that genetic testing. And at that time, I was so super productive in my practice, I could have paid for that, no sweat, whether it was a discounted price or even if it was what the insurance would have had to pay for it. Either way, I could have afforded it. And if someone had given me the opportunity, and if someone would have just been honest and said, I don't know if your insurance is going to pay for it, and I don't have time for it, but it'll cost you $250 or $1,000 or $4,000, whatever the number was, I would have paid for it. And so sometimes we have to ask ourselves as well, like, why am I declining this thing? Why am I saying no? Because it's going to cost me time, effort, energy that maybe I feel like I don't have. Or am I worried the patient can't afford it, or that the patient wouldn't want to pay for it? Ask the patient, ask why it's so important to you. Ask, you know do you know if your insurance covers it? Now people come in and they're like, oh, I know my insurance covers this because I already asked.
Yeah.
Or I know I need to meet these criteria in order to get this covered. Can we do these tests to see if I qualify for this thing? Right. But I just think, as providers, we got to pump the brakes and ask ourselves, why are we denying a patient something they need? And also, are we the person qualified to deny them? Because at the end of the day, only a genetics counselor could tell me yes or no with expertise that I did or did not qualify for that testing. Now, either one of those providers could have ordered that test. I ordered genetic testing, but more than anything, I refer to a certified genetics counselor because that is their expertise. And so, is this my expertise? Should I make this decision? And if not, who do I refer my patient to that is qualified to do so?
Super powerful stuff, and I really sincerely appreciate you sharing your experience with our listeners and our subscribers. So, Dr. Alexia, can you share some three practical tips on genetics for healthcare? I always ask our guests, looking back in their journey, there's people out there who are watching this that are going through similar, footsteps, walking a similar path. And by you sharing your story, you're really helping them to understand how they can talk to their provider, how they can talk to their family members to become more effective advocates for the care that they feel they want and need. So, can you share three practical tips for anybody who may want genetic testing and have been told, by a healthcare provider that they don't qualify or they don't meet guidelines, and may have similar concerns as you did, or not even necessarily for testing, but who may want a certain course of care or a procedure, that their providers are pushing back on?
So, the first thing I would say, when you're preparing for a visit, like, be prepared for how you're going to tell your medical history or how you're going to tell the story. Sometimes things get lost in the sauce because people present what another doctor told them, but not usually something that's medically relevant, or why they're mad with another doctor. Not helpful. People don't present their story in a concise way because time is of the essence and you don't want to run out of time on your visit giving a prolonged story with unnecessary, unhelpful information. And make sure you're reporting your symptoms, not what you believe to be wrong, your symptoms. What are the things that you're physically experiencing or seeing in your body? What makes it worse? What makes it better? And know your family history and know it in detail. And like, have as much of that information presented ahead of the visit as you can, because it will start the doctor's wheels turning before you ever enter the room, right? So, send records, relevant information ahead. The second thing is, ask why, right? If the doctor is not offering testing that you feel you believe, then ask why they don't believe you need it, or can be prepared to convey information or support why you feel that you do believe it. And if that means you need to Google or use AI or whatever, that's fine. But, again, report that in a concise way. Dr. So and so, I want this genetic test. You suggest that I don't need it, but the NCCN guidelines say that I, as a young Black woman with breast cancer, should get genetic testing, or because I have this family medical history of, this cancer, and this cancer, I qualify medically for genetic testing, right? Come with the information. Um, don't come in with a stack of things, don't come in with 30 questions. Be listening and be fully present. Don't just wait for your doctor to shut up or be quiet, so that you can just ask a question. They may have already answered that question. So be receptive to what is being said. And then lastly, always get a second opinion, particularly when it's coming down to a diagnosis of a genetic mutation. Make sure you're getting the right referral, or ask for a second opinion if you're not getting that information somewhere. If it comes down to chemo or surgery, if it's not going to significantly delay the start of your treatment, get a second opinion, and get a second opinion even if you've already had surgery and you've already started your treatment. I think these are ways that we can get the absolute most out of our healthcare providers, while also in turn being mindful of our healthcare providers, because I think that gets left off the table as well.
Dr. Alexia Gaffney Adams, cancer conqueror, PALB2 mutation carrier. Thank you so much for sharing your powerful story and testimony for our audience here on Genetics for Healthcare.
Thank you for having me, Rome, and thank you for having this most important platform, because these are things people aren't thinking about and they aren't considering. So thank you for sharing your expertise and for building this platform and sharing yourself with all of us on it.
This is Genetics for Healthcare, a podcast for patients.